indeed, during this webinar, I will talk about a research interest of mine, sound sensitivities. Probably a lot of you struggle with tolerating sounds, and I can imagine it's sometimes a difficult route to find the right professional to give you a kind of diagnosis, and B, then definitely a treatment plan. So in the research field, hyperacusis was studied a lot together with tinnitus, but luckily it's getting more attention as a symptom on its own in the last years. And that leads to, luckily, also more research on it. So thanks to Fabrice, I don't have to do a lot of introduction myself. So my name is Dr. Laure Jacquemin. My PhD focused on treatments for tinnitus mainly, and hyperacusis was always a part of it. But during my postdoctoral research, I focused mainly on hyperacusis, from its diagnosis to its treatment. And as a clinician, I provide counseling and therapy to patients with tinnitus, hyperacusis, misophonia, mainly based on the principles of cognitive behavioral therapy, or CBT in short. And indeed, I am from Belgium, so I'm not a native English speaker. My apologies for the accent. So let's start digging into these sound sensitivities. I will talk about some definitions of sound tolerance disorder to support the diagnosis, the effect that a sound sensitivity can have on someone's life, the potential working mechanism behind hyperacusis, what hyperacusis and tinnitus have in common, but also what not. And in the end, I will discuss different treatment options, because yes, there are treatment options available. And as Fabrice told, at the end of the webinar, we will do a live demonstration of the TINNIBOT app, and there will be time to answer your questions that you put in the Q&A. So, sound tolerance disorders. What's in a name? To be fair, the vocabulary and terminology used in this field is very heterogeneous, very imprecise. It ranges from reduced sound tolerance, a decreased sound tolerance, a loudness tolerance disorder, collapsed sound tolerance, or lately more known hyperacusis. Are they all the same? Well, the field is definitely still in discussion on it, but I will try my best to give you some guidance on what is hyperacusis, but what is also not hyperacusis. So the latest definition that researchers and clinicians agreed on for hyperacusis is that hyperacusis is a general hypersensitivity or hyperreactivity to sounds, which are well tolerated by other people or by the person itself in the past. The term hyperacusis literally means excessive hearing. It has already been mentioned in the medical literature over 80 years, but like I said, minimal attention has been given to it, sadly. And at the moment, several definitions and terminologies are still out there in literature, but I hope this latest definition can help us to agree on what hyperacusis is and to study this specific symptom. So more specifically, hyperacusis, what is important? It's, for example, important that the person itself did develop it during the years. So some people say, I was born like that. I just don't like sounds. I'm bad at tolerating them. Well, then it might not be exactly hyperacusis. So when hyperacusis happens, we see a development. The person could tolerate it well in the past and now not anymore. But I think it's important to see this not as a black and white phenomenon. Is it really a disorder or is the variant of normal? That really depends on patient to patient. In my view, it's a disorder if it impacts your quality of life. But you can have some sound sensitivities that are perfectly okay or normal to you and they don't impact, and then it might not be a disorder. So why is it not black and white? Sound in general is sometimes made to be dangerous for our ears, sadly. Many of the sound alerts have been, for example, designed to be as annoying as possible, asking our attention. Think of the sounds that they use to chase away young people around the station areas, or to chase away animals, for example. But sadly, also sound has been happened as an acoustic weapon. So sound is not always something pleasant, and that is normal and that's okay. But our tolerance also varies with context, with mood, with anticipation. Let me give you some examples. When you're waiting for a very important phone call and the phone doesn't ring and doesn't ring and you're waiting already for hours and then suddenly it rings, you will almost jump out of your chair, not because it's loud, just because for your sound sensitivity at that moment, it will be very loud in your brain because you were waiting for that call. Or if you have an annoying neighbor that already makes a lot of sounds in general, and then the annoying neighbor starts during this webinar, for example, make a little annoying sound, you will be way more annoyed because it annoys you during this webinar and you want to listen. But also it's again that neighbor that already makes a lot of sounds. A mom, for example, that is focused on the breath of her ill baby. All examples how the loudness of a sound can vary just depending on our context, our mood, our anticipation, and not on the physical loudness it has in real life. Also, if we're stressed, if we're tired, if we're anxious, we will be more sensitive in general, and so also more sensitive to sounds often. But it's normal to dislike specific sounds. And like I said, it's not a disorder if it doesn't impact your quality of life. I hate it when people do fingernails on a chalkboard. Some people hate it when the tap is dripping, when a pen is being tapped, and so on. So for hyperacusis, it's also important that it's a general hypersensitivity. It's not that you're sensitive to a few sounds. No, you're just sensitive to the daily sounds. The daily world for you seems too loud. You cannot tolerate it well. It has an impact on your emotions. Sometimes it's even a painful perception. So there is this physiological arousal going on. And often a lot of people will start to avoid the sounds that give this negative emotion or painful perception. It's very human when you don't like a certain sound, when it has a negative impact on you, then you will just start avoiding it. That is more pleasant. So a lot of patients with hyperacusis, they will constantly scan the room, like we say. They come in a restaurant, in a cafe, with friends, they will immediately see, okay, where is sound coming from? Where do I have to sit? Oh no, there is a loud table there. There is a music box playing there. So we see an increased attention to auditory stimuli or to an increased attention to sounds in people with hyperacusis. Let me give you some examples of what hyperacusis is not. We have also a symptom that is called recruitment. This goes hand in hand with people with hearing loss. So what we see with recruitment is that at certain frequencies, at the frequencies where you have a hearing loss, you will have an abnormal larger loudness at an elevated threshold. So what I mean is that the loudness growth is steeper at frequencies where you have a hearing loss. So moderate intense sounds will be perceived as very loud. You have to think it as, okay, we have hearing loss, so we have a smaller range of levels that are just audible, and then it's already easily painful. So there is less room for a normal growth. We see that it's a steep growth in loudness and that moderate sounds suddenly sounds very loud. This all has to do with the outer hair cells that are damaged, but I will save you more details on that. But recruitment, what is a typical phenomenon, or when you might have recruitment, is when you ask people to speak louder, but when they do, you will say, oh, but not that loud. That's what I mean with that small dynamic range. People speak louder to you, but it's often already too loud. So it's not hyperacusis because it's not for everyday sounds. It's really often for the frequencies where you have a hearing loss. And recruitment will not really depend on your moods. It's more of a physiological thing that is happening in your ears and your brain. We talked already about misophonia. Also, that is not hyperacusis. What is different? Well, misophonia is that symptom where you have a decreased tolerance for specific sounds. So specific sounds or stimuli associated with these sounds. And the set of triggers really differ across patients. Literally, misophonia means hatred of sounds. So, for example, you dislike chewing, sniffing, slurping sounds. These are very typically. The reactions will definitely depend on your history, but also on the context. So it's often related to other people making these sounds, and often specific people even. So a typical example is a teenage girl that hates when her mom is slurping. That is a typical phenomenon of misophonia. People with misophonia are aware that their response is disproportionate, so they really get angry a lot of the time. They get really some hate, some disgust toward people making these sounds, and they don't want to feel like that. So they know it's disproportionate, but they cannot see how they can react differently. Just on a side note, there is something called misokinesia, which is quite similar. It's not with sounds, but it's with movements. So people that cannot stand repetitive movements. I had once a patient that had both. It started all with specific sound she could not tolerate, but by time she didn't find help and it kept increasing and it kept worsening. And after a while, she also started to hate it when people made movements with their legs in a repetitive way, and she really had to block her view from it because she could not see it anymore. So like I said, this is not hyperacusis because it's for specific sounds, and with hyperacusis, there will not be that much anger going on. Misophonia, your emotional response is very strong often. So like I said, it's typical phenomenon in adolescence. I had a lot of patients with it, like also in their 20s, beginning 30s, but it can happen across the age range, definitely. So I know this is probably not a full answer to maybe all of your questions concerning what is what, because there is still some discussion going on. What definitely is true is that all these kinds of sound sensitivities involve some physiological aspect, but also some psychological aspect. The terminology is not great, but luckily it's improving. There is more research going on. So now with hyperacusis, we have a definition that a lot of people agree on, and we hope to be able to work from there. And yes, it helps us for research, because if we take too many people that are too different all together, it will be difficult to study and to find a treatment for all these people that are very different. So it helps to make a good diagnosis. And so it helps also for you to define, okay, do I have hyperacusis or is it more misophonia, for example? Because also that will influence how the treatment plan will look like. For the next steps in the presentation, I will mainly focus on hyperacusis because that is the main topic of today. So the prevalence of hyperacusis, it's difficult to say how prevalent it is. There is no real consensus on the diagnostic criteria. Like I said, there is now a definition, but still there is some discussion going on. And that makes that the range of hyperacusis prevalence varies in the literature from 3 to 17% in the general population. There is definitely some people where it's more prevalent in. Prevalence is higher in women, and women often also score higher on the hyperacusis questionnaires, so they have a higher impact or higher severity. Also in young people or students, but also in older adults. Of course, in people with hearing loss and people with tinnitus. So there is definitely still some overlap or so comorbidity with hearing loss and with tinnitus. We did a study ourselves on how patients with hyperacusis present themselves in the clinic, and our study showed when you have hyperacusis and tinnitus together going on, there is often also a higher mental distress. So for us, it's a bit of a red flag when people have tinnitus and hyperacusis that both impact their lives, because often that will lead to a higher mental distress. Hyperacusis, the experience can be very complex. Richard Tyler, a known researcher in the field, once tried to make subtypes of hyperacusis. Probably you've already read about it, that you have something like annoyance hyperacusis, loudness hyperacusis, when it's more involved about the loudness of the sound that you cannot tolerate, fear hyperacusis when you're fearful from sounds, pain hyperacusis when they cause you pain. But as people here in the audience will also some have sound sensitivity, try to put you in one of these boxes. A lot of people will be fearful and have pain, for example. So many patients experience 2 or more of these aspects. So lately in the literature, we try not to work that much anymore with these 4 subtypes because it doesn't really apply. But it says something on how it can present in the clinic about all the things that can go on with a patient with hyperacusis. But in general, we cannot deny it. It has an impact on someone's quality of life, and it can be quite severe. It can lead to discomfort, to headache, to concentration difficulties, to fatigue, to anxiety. In general, we see that it results in an impairment on social level, on an occupational level, so at your work as well, or at a recreational level. You will stop doing some leisure activities that you were liking. So people will start to do alterations to their work, to their social habits. And what we see is also that 56% of patients with hyperacusis, so more than half, experience at least also one psychiatric disorder. So there is definitely some comorbidity going on with anxiety, for example, that goes often hand in hand. Hyperacusis can also lead to mental distress problems, to sleep problems. So yeah, when you have hyperacusis and there is an impact, the impact can be quite intense. And that's also why you start doing all these alterations to your work and social habits. Why is hyperacusis happening? Well, there are some theories, and sadly, I cannot give you one theory that applies to everyone. The most followed theory is the central gain problem. Let me try to explain it as easy as possible. The central auditory system becomes more excitable when people hear less. So if you see here on the image, you see the auditory pathway. So a sound travels from our cochlea in our inner ear to the auditory cortex in the brain. And so we see that when people have hearing loss, they have less input at the inner ear, so at the cochlea. The auditory nerve, that's the first that you see there, has less input. The cochlear nucleus is the next step in the auditory pathway, also that receives less input. And then we see a compensatory mechanism going on. Further on the auditory pathway, there is like this volume button that is increased. The volume is increased, let's say, in these higher auditory brain areas. So our brain starts to react more because we hear less. Let's try to imagine it as our auditory system trying to optimally use our input range, so we hear less. So it tries to use more of when we hear something, it increases the volume to make it audible. That's the theory of central gain, that there is a hyperactivity to just spontaneous activity or hyperactivity to sounds because we hear less. That's a nice theory, but also probably here in the audience, people might have a normal hearing according to their audiogram. So what's with patients like that? Then this theory doesn't apply. There are some theories that maybe even if you have a normal hearing on your audiogram, you might have a hidden hearing loss, there might be some hearing damage, but still I think it's difficult to think that this theory can explain hyperacusis in every patient. Also think vice versa, why then does not every person with a hearing loss have hyperacusis? So I definitely believe strongly that this mechanism is happening, but it might not happen in every person, and it might be one of the puzzle pieces. I think this system is not enough to explain it all. What we often see is that there is also a more emotional part to it. So this is a very physiological thing that's happening. But what we see also in the brain is that our auditory area is connected to our emotional area in the brain. So how we perceive certain sounds, how we think about sounds, how we feel about certain sounds, the connections, the emotional connections that we have about certain sounds, the thoughts we have, that will influence if we will hear sounds more intensely or not. So some people might have a fully normal hearing, and then the theory of that central gain is difficult to apply. But maybe you first experienced tinnitus, and that was a very intense experience, a very negative experience, which made your brain started being anxious for different sounds. You start being anxious to develop hearing damage. So you start to perceive sounds as dangerous, as risky, as and something negative, and that will influence how loud we will hear this sound. Imagine if you're scared of dogs, you will hear already a dog from 2 kilometers further, not because you have a better hearing, just because from the moment your brain detects there is a dog somewhere, you will hear it. And it will come into your attention. So yes, there is something physiological going on, but there is definitely also an influence of our own emotions and our own thoughts on how we will perceive a certain sound. Think also of the beginning of this presentation, the examples of how if we're anticipating on a certain sound, it will sound louder. If we already have a negative experience with a neighbor, all of that will influence how we will perceive a sound. So we cannot disconnect our auditory system from our limbic system or our emotional system. And then there is something like pain hyperacusis. Some people say, yeah, I have hyperacusis, but I also really feel a sharp stabbing pain in my ear, in my head. Recently, some researchers found that there is an alternative pathway going on from our cochlea, so in the inner ear, to the brain that can explain why we can experience pain in our ear. So there is some perception that we can feel what is going on in our inner ear. However, it will also be a kind of hypersensitivity that's going on there. So when you feel a kind of pain hyperacusis, the pain will probably not be really happening at your ear level, but you will be more sensitive to the painful stimuli that travel from your inner ear to your brain. So it will be also that volume button that is increased, not only for sounds, but also for the painful perceptions or the tactile stimuli in our ear. Of course, future research questions. Now we know that that pathway is happening. Can we target that pathway to reduce pain hyperacusis? I cannot tell you yes or no yet. Also, can this lead to more centralized or more chronic pain over time? These all are good questions for future research. And then what is now going on with hyperacusis and tinnitus? Do they Is it always something that happens together? Definitely not. There are patients with tinnitus without hyperacusis, and there are patients with hyperacusis without tinnitus. But what we see is that they have a lot of similarities, definitely. So there is an overlap in prevalence. We see definitely more patients with hyperacusis in a tinnitus population, and we definitely see also more tinnitus patients in a hyperacusis population. So there is an overlap. Also, that large overlap suggests that there is something that happens together that can explain both symptoms of happening. And that is that central gain model again. So if you think again of that hyperactivity in your brain because you hear less, well, that hyperactivity, when that's spontaneously happening, that will lead to tinnitus. When that hyperactivity is in response to sounds, that will lead to hyperacusis. And it's important to know that both tinnitus and hyperacusis can be worsened by anxiety and stress. And in each, there is an increased incidence of depression. So we see also there that comorbidity influences both symptoms. Also, so far, a lot of treatments are quite similar that are proposed for hyperacusis and for tinnitus. So elements of tinnitus retraining therapy and cognitive behavioral therapy are used for people with hyperacusis, often also combined with some sound-based treatments, and I will come back to that in a second. Until now, I think hyperacusis was often treated together with the tinnitus or treated really in the same way as we would treat tinnitus. I think that is not fair. I think hyperacusis is definitely something that stands alone, is possible to stand alone, and needs more research on how we can treat it specifically. But we can also not deny we see very good effective ratios of doing these treatments for tinnitus, adapting it to hyperacusis, and we see that it has a good effectiveness. But like I said, they're not the same. It's a different perception. If you think of tinnitus, it's often, for example, in one ear, it's very intermittent. It's also very primitive, what you experience there, a very formless sound. While hyperacusis is often bilateral, but can also definitely happen unilateral, but in most patients bilateral. It is rarely intermittent. It's often a constant thing. It's not that you're at one moment in the day sensitive and in the other moment not. No, it's something that's quite constant, and it's a very vivid and salient experience. It's not very much known so far, but that's just because research is lacking, is how much self-help can be effective for hyperacusis. And I think TINNIBOT is a great tool to start researching that, is how far we can get with self-help for hyperacusis patients, but there's less literature to support it. There are also some researchers that questioned, well, with tinnitus, you have an influence from your neck and your jaw. We call it somatic modulation that is happening with tinnitus. So far, it was thought that that would not happen with hyperacusis, although recent very preliminary research at our university hospital shows that also there might be some influence from neck and jaw on hyperacusis. But that will definitely need more research in the upcoming years. And then I think, most importantly, how can we treat hyperacusis? Well, there are some different options. First of all, if you are a hyperacusis patient and you're wearing a lot of hearing protection, well, that's already where we have to start our treatment. A lot of patients started using hearing protection after tinnitus, for example. They were so scared of having, again, a noise damage that they started to wear ear protection. Or maybe even worse, maybe a professional advised you to, well, if you cannot tolerate them, avoid these sounds. Well, sadly, we see it's not a very helpful behavior. It's actually doing the opposite of what you want. We see in experiments when we ask people to use ear protection that they start being less tolerable for sound. So they can less tolerate sounds than before they were using ear protection. And while it might feel painful, that doesn't mean it's damaging. So what is difficult when I treat patients with hyperacusis is they're scared to wean off their ear protection, because they're like, yeah, when I hear these sounds, they're painful, so it must be damaging. And when you think of what I just told you earlier, all these hyperacusis symptoms are happening at a brain level, not at your ear. So it's not damaging for your ear. The volume is really increased at the level of your brain. So while you might not like certain sounds, while they might not feel comfortable, that doesn't mean they're damaging. To be damaging, a sound has to be very loud and for a long period present. So for example, an ambulance that passes by, I also don't like the sound, but it's so short that it cannot damage your ear. Of course, there's another story when you're with your ear for an hour next to that ambulance. When a train arrives, also that, again, I don't like the sound myself, but I'm not going to protect my ears because I know this is not damaging. It's too short for that. So it's not a helpful behavior. It's doing more bad than good. So we will help patients to gradually decrease it. And it's like a training program. You cannot tell a patient to just stop using ear protection on all levels. No, it has to be gradually decreased in time and in intensity. It's really like a training program. Sometimes it will hurt, like I said, sometimes it will not be pleasant. But when you're, for example, training your muscles, sometimes you also have muscle pain the next day. And you know that's part of the training program and that's part of the growth. And that's the same for hyperacusis. Of course, don't push it too hard. That's why I find it a step-by-step approach. Avoid other negative experiences. So it's something you can really be guided by an audiologist. Why is there a post-it here on the slide? Is because I use post-its with my patients. I just let them put down on post-its all the sounds they cannot tolerate and they protect themselves from. And then they have to rank it from easy to difficult, in the sense of like, okay, what would be quite easy to stop using my ear protection and what would be super difficult. And then step by step, we will attack every post-it. So it's really a training program. It's exposure in its pure sense. But there is also something like sound therapy that can help. It's a bit of the same theory. Well, while you start avoiding sounds, actually sounds are good for your brain. So we have to feed your brain with sound to start learning again what is soft and what is loud. When you constantly wear ear protection, your brain doesn't know anymore. So we have to give sounds to your brain so they know again what is soft, what is loud, and they don't overreact to it. So just in short, what you can do with sound therapy is present a white or a pink noise on a low level, not a too loud level. It just has to blend in, like we say. It can be through a sound device or an app, like on TINNITUS, which Fabrice can definitely show you later, but it can be also through hearing aids, for example, or just an environmental sound. People that don't have apps and don't have hearing aids, they sometimes just use the sounds of their environment to feed the system. Day, nighttime, there is some discussion going on, and there is definitely some clinical evidence that it might also be helpful to feed your brain at nighttime, and it's easier because you're less aware of it. So to at least at these moments give some sound to your brain. But so it's important, what is sound therapy? A neutral sound that is present at a low level, and by that we try to recalibrate your house alarm, like I say. Now your alarm goes crazy for a little fly, and we want to recalibrate it so it only goes off for a thief and not for that little fly anymore. Hearing aids can definitely be helpful. While it sounds a bit counterintuitive that hearing aids, they will increase sounds. That's something people with hyperacusis will not like to hear. Of course, it's important to first wean off the ear protection, and then we can start to use the hearing aids. Also, again, increase it step by step. So it's definitely a cautious approach. We see that a lot of people with hearing aids don't like their hearing aids because it goes too fast the process and they get a dissatisfaction with the amplification. But actually a hearing aid is also a great tool to expose yourself gradually to more sounds. We can, for example, put first in the hearing aid just some sounds like the neutral sounds that I just talked about without any amplification, and then step by step amplify sounds again. And then last but not least, cognitive behavioral therapy. It is the therapy where there is most evidence for in literature for hyperacusis, and also in my clinical experience, it works very well. CBT is aimed to alleviate your anxiety by adapting your dysfunctional cognitions, so your thoughts about sounds, and also targeting these safety-seeking behaviors, that avoidance behavior. So it's working on your thoughts, but also on your behavior. And I think there is a great quote that just summarizes what CBT is all about. And it's by Gandhi, and it says, keep your thoughts positive because your thoughts becomes your words. Keep your words positive because your words become your behavior. Keep your behavior positive because your behavior become your habits. Keep your habits positive because your habits become your values. And keep your values positive because your values becomes your destiny. And I think that's what CBT is all about. It's about targeting those thoughts that you have about the sounds that you're experiencing. So in CBT, we will try to make give an insight in the vicious cycle that is happening in your brain. So yes, a certain sound will give that first emotion. The sound traffic will give you an anxious feeling, but very, very, very fast we will have some thoughts about it. We will think, why would someone create such sounds? I will not be able to tolerate. I won't be able to socialize. I'm missing out on life. I cannot enjoy my life like this. Of course, these thoughts will lead to more emotions and sensations because there are negative thoughts that will give you even more intense emotions. And then that will even feed into your thoughts, and your thoughts will become even more general and sometimes more irrational, in the sense of like you will start blaming yourself or blaming others. You will say, I'm not normal. How am I going to live with this for the rest of my life? So you start to think about the future and all this stuff. And that feeds into that same loop. And while we are not monarchs in Tibet that can tackle those emotions that we're feeling, we can tackle them by changing our thoughts and changing them to more helpful thoughts. And this is not coming just out of my head. There is a lot of studies that already happened about it with CBT, also for hyperacusis. So a comparison between people that receive CBT versus a waiting list, we saw that both groups improved. That's a good thing. Also the waiting list, by just maybe know that they will be helped in the future, for example, will already decrease some anxieties. But the CBT group had a larger improvement. However, in this study, there was no effect on the anxiety. Might be that you need more general CBT for your generalized anxiety, of course. But there's also some evidence even on iCBT, so CBT that's delivered through the internet. There is some evidence that when you have audiologist guided iCBT or face-to-face, it doesn't matter, they're equally effective. And when we compare iCBT versus just monitoring a patient and not doing anything, we see greater improvements for the iCBT group. So CBT is effective, and luckily it can also happen through internet and smartphone applications. And also with TINNITUS, there will be more news and more results about that in the future, definitely, on how also an app can help you. It is the fact that there are huge waiting lists for psychologists, huge waiting lists in hospitals. Sometimes you live too far from a hospital. So it is great if you can see just an audiologist through video or through an internet platform or even with a robot like TINNIBot. So to just summarize before we go into the demo that Fabrice will help me with, hyperacusis is a very heterogeneous condition, and we have to more subtype it in for research purposes so we can know what helps for who. It is associated with hearing loss, with stress, with anxiety, and with depression. So it doesn't stand alone, and it's important as a patient to also see those links, to also tackle those other comorbidities that are going on. It's difficult to tackle your hyperacusis without tackling your anxiety or your depression or your hearing loss or the stress that is going on. There is definitely a lot of similarities and overlap with tinnitus, but it's not the same. And treatments need to be personalized, like I said, but strong evidence is out there for exposure. So for instead of avoiding sounds, exposing yourself again to it, and for cognitive behavioral therapy.